present here a 65-year-old gentleman who has a very interesting coronary artery disease. He presented for primary PCI to the proximal RCA with a bare metal stent. It was a driver stent, 3.5 by 12 millimeters. And he also had a bare metal stent in the posterior descending artery. That was in 2009. He subsequently presented with stable angina, and he was stented on the left anterior descending artery. After that, in 2022, he had a rotablator assisted PCI to the circumflex for unstable angina, and he had another distal RCA to proximal PDA rotablator assisted PCI of the RCA for unstable angina in May 2022. At that time, there was mild to moderate ISR in-stent restenosis in the proximal BMS stent in the right coronary artery. The patient was subsequently hospitalized for angina in November 2022. At that time, he was discharged on medical therapy because the nuclear scan showed no ischemia with a normal ejection fraction. Otherwise, the patient is known for hypertension, cholesterol, and he's an active smoker. So he presents to the hospital again with a diagnosis of unstable angina. He has increasing chest pain for the past 4 weeks, negative troponins, and unremarkable ECGs. We have repeated the coronary angiogram yesterday. Next slide. So the left coronary artery was unremarkable. It was unchanged from 2022. However, there was progression of disease in the prox and mid right coronary artery segment with moderate to severe in-stent restenosis and also a severe lesion distal to the stent that looked long and calcified, greater than 20 millimeters.
With us, so as you can see, this is the rule of fives. So more than 50%, more than 5 millimeters in length and 5 millimeters in terms of depth. We absolutely have it right even before the stent. The stent is around the 17 to 18 millimeter mark. You could see that within the stented area, there's not much calcium, but there's clearly intimal hyperplasia. We're coming out of the stent now, and again, you're seeing a lot of calcium. There's a fair amount of calcium in the medial aspect of the artery. I think it was 2 o'clock and 7 o'clock. And again, as we're nearing the ostium of the RCA, it's fibrocalcific, more fibrotic, closer to the ostium, but towards the 40-minute mark, 40 millimeter mark, you can also clearly see around there, there's calcium, I think. Due to the data, the information that we gained from this OCT run, I think it's clearly not necessary to proceed with atherectomy. And I think what we will do is POBA, plain old balloon angioplasty, and then move on until proven otherwise to IVL to really crack the calcium. And
we also plan to use cutting balloons inside the stent just because of the severe intimal hyperplasia. So cutting balloons allow us to open up the scar tissue, improve the delivery, and also improve the expansion afterwards, and should be used in cases of intimal hyperplasia. So this is another area where the OCT helps us choose our balloon.
20, maybe? The 20 book.
Yeah, the 20 millimeter.
Yeah. So this is in-stent also more towards the distal aspect. So you saw proximally and maybe a bit before the 18-minute. So the lumen is actually really narrowed.
Yeah, and it looks homogeneous.
Yep.
So this is the hallmarks of intimal hyperplasia, but there is a bit of neoatherosclerosis at the outflow of the stent.
So you see
as well.
You see the stent. So we're clearly still in the stent. So with that, we're going to proceed now with.
So we have a JR4 guide. We have a run-through wire, I believe, and we will start first with the cutting balloon. We took a Wolverine 3.0 by 12 millimeter balloon, and if we don't have enough support, we're going to have a guide. We have a Guidezilla ready on the table that we will proceed to use to increase our support. We're going with the cutting balloon in stent. I'm at 8.
And with
so this is around 3.15 millimeters. We actually measured inside the stent. The stent is a 3.5. It looks like it was expanded around 3.4 millimeters.
Off. So initially we found the the initial reports from 2009. It was a BMS 3.5 by
on 10.
3.5 by 14, which was not post-dilated.
12. This is the maximum rated pressure, 3.28 millimeters.
Off.
Looks like a good expansion.
Yep. What we could proceed with as the next step in terms of the angioplasty, I think here at this juncture, since we have the information from the OCT, I think going in with an NC in and around the stent will not be favorable in my mind. We have to get stent expansion. So since we measured everything initially. Here. Go. So it's expanded more. So the plan is to go ahead and proceed with IVL to really crack the calcium. And with that, we'll proceed with the shockwave balloon.
Yep.
So since that's resolved, what we could do is if I see that in the coming minutes we don't have access to the shockwave, what we could attempt to do is get an OPN 3.0. So try to crack, and then once we use the OPN, we could move towards another OCT assessment. Because at the end of the day, what we really want is to be able to cause fracture that ideally are visible. There is data out there when you talk to KOLs such as Ziad Ali. He has mentioned there are studies that show that even though we might not see necessarily on OCT some fractures, there might be some micro fractures that you could have as well using IVL. But with OPN, I mean, ultimately what you want is fracture. So if the IVL is not available, then as a fallback plan, OPN is the next one. I would not necessarily favor a standard NC as the pressure that you can gain versus a double lumen balloon such as the OPN might not be able to obtain the crack that we want. The deeper calcium that you saw in OCT will not allow us, will not be adequately treated with cutting balloons as meant by different algorithms. That's not something that we would favor. What they usually recommend is around 6 atmosphere, a sort of some will say 1:1, others will say a upsize by 0.5. Unfortunately, when we had prepped the case, we had the 3.0, but in the meantime, we have 4 labs running at the same time. The 3.0 is no longer available. So we'll make do with what we can, and we'll see what we can do with the 2.5 and assess by imaging. So if the 2.5 does not do what we want, we'll head for an OPN. So we have 80 runs. And what we're doing right now is we're upsizing to 10 atmospheres. So obviously this is sort of not what is ideally recommended. But ça se peut que vous ayez des douleurs. I think with the audience that we have, the question pertains more to the interventional aspect. And as Robert mentioned, the landmark study that recently has been published, the Renovate Complex PCI. If we follow the definition of their complex PCI, I think for us to get into this same scenario, a scenario of in-stent restenosis, we really have to be careful and cognizant of the data and modify our strategy according to the data that we're obtaining from imaging to then decide a strategy. And as we initially, we're at 12 atmospheres.
So this is only a 2.5 balloon. We know the vessel measures at least 3.25 to 3.5 millimeters. It's severely calcified at those lesions, so we feel comfortable going
Oui,
higher.
fentanyl 50. Il y a des douleurs, c'est normal. On travaille dans l'artère.
Patient
monsieur.
having chest pain at the moment because of the shock wave and the prolonged inflation. So this is expected in this type of therapy.
This is actually a good sign. We're
Means we're
physiology
treating.
and clinic is on the side of us intervening. We're 12 atmosphere. So we've all usually we talk about doing IVL. So doing IVL will c'est fini. I think we can do
Maybe a bit more proximal.
okay.
Okay, so
Lose
12 atmospheres. This is the 6th treatment. So we already gave almost 60 shockwave treatments out of the 80 that is allowed per balloon.
Yep.
So we delivered 6 therapies.
we'll keep 2 just in case we
We'll keep 2 in case we have trouble delivering the equipment or we don't get.
so it's really optimizing and then I think it with OCT the MLD max sort of approach, and it was recently discussed. So we see
Beautiful.
dissection. So that means we did manage to crack something. So that's good.
There is
So
a dissection proximal to the aneurysm.
And
That's where
distal.
we went with the shockwave and also at the stent
Okay,
area where we went with the cutting balloon and the shockwave.
we'll do OCT now just to assess what we got.
So
right.
we're right at the aneurysm. You can see the angio. I'm going to go in the live view.
If you hopefully you can see this,
Yeah,
right?
We're doing the catheter is winking at us, so that's a good sign.
Great.
All
We
right,
break
we're
it
going
down.
to change the injection parameters.
So we use 4x18 and 400 psi.
It's going to make sure we get good clearance, so that looks good.
Okay.
And enable pullback.
Auto
Calibrate.
calibrate. Yep.
First.
And you'll see this live.
Enable
Like
pullback.
Okay.
Cine.
Yep.
Perfect.
Excellent. So we'll look at all of this together. For IVL use, there's some fractures that you see, so that's good, and dissection as well. And this, again, some dissections here.
So that's expected with the cutting balloon that we used and also the shockwave.
This is the shockwave that we used with a 2. And remember, this is a vessel that was initially, well, I think we have some fractures as well in the distal end.
I think our objective here with stenting will be to stent from the aneurysm all the way to the almost to the ostium actually.
Yep. I think we have
so it's almost like a 40 millimeter.
Yeah, 48. Est-ce que tu peux mesurer Mike, de l'anévrisme de là?
Do the lumen contour?
Oh, no, it's just the length. Yeah.
This is a 3.0. You can see it's the 3.0
okay.
vessel.
Then we're going to measure the length.
Yeah.
From
all
there,
the way to the ostium.
Maybe to the ostium. At least we cover
42.
42. So we're going to have to do it with
probably
two stents. Okay.
3.38.
Versus we could get the 48, the synergy 48, and then it covers a bit further down. Yeah. Okay. So we'll get a 3048.
So we use the DS synergy. It's a 48 millimeter stent that we aim to deliver all the way in the mid to distal portion
très bien. On a réussi à
faire to the ostium.
Okay.
This will minimize the chances of us missing the stent overlap. And will minimize also the risk of restenosis. It is a very long stent, which will increase the risk of restenosis. But,
however,
in this patient, there's disease everywhere.
There's disease. There's and also what my strategy to try to use one stent is to have less issues with overlap.
Exactly. There's a bit of resistance there, but not much effort. Dr. Lee made this look effortless.
It was a big effort. No, I'm just kidding.
This is years of experience.
Yeah, I'm getting old. 15, 16 years now.
15 years.
So it's actually a privilege to work with my younger colleague. Okay, everyone. I think we're covering everything.
Laurel?
Yep. You might want to pull back a bit. Yeah. Okay.
On?
Yep.
On. I'm going
275.
We're going to take this to 18 at least because we know it's a 325 vessel. So the stent outer diameter now is at 3.22 millimeters.
Yep. Ça se peut qu'il y ait des douleurs, c'est off.
Off? So we see we covered the ostium. There is a good blood
coverage.
return in the aorta. We're removing. This is a very long balloon, so we have to take our time when removing it.
This is it. We're at 18. So obviously.
Non-compliant balloon 3.5. 3.5 quelque chose, 20.
So we're just going to optimize this with a 3.5 by 12, and then head to finish with the imaging.
The patient has 7, 8 out of 10 chest pain, but we put such a long stent.
Yep.
And we'll occlude the vessel multiple times, so expected. We're just going to pose that lit, and we're just going to make sure there's no complications.
Yep. So he's hemodynamically stable. There's no evidence of perfing. I think the initial reflex when the patient has pain is to go shoot more contrast and go see. But clinical cues right now, despite the chest pain, does not point to a major complication. So we'll move along with a post dilation before completing this with imaging.
This is where the previous stent was. 18, 18.
Off. On.
This is where the previous BMS was. 18. Off.
Okay. 1.
18, 20. Off. A bit more back.
Yeah.
That's it. 20.
There you go.
Oh, okay, this looks good. Okay, off 20. Trying to make sure that we pose out at everything. So we know at 3.5 we're 1-to-1 with the vessel.
So I'm just making sure the ostium is okay. Okay.
I'm gonna do here something we call the TAN. So we're gonna toss some blood, do the ACT, and give 1 cc of nitro.
Yeah.
Robert
has all of these.
I have acronyms.
Nifty acronyms. So
I think that looks fantastic.
I think we're pretty happy with the results.
Yeah. Should do the OCT.
Yep.
So we image distal to the stent all the way to the osteal RCA. So we can also use the angiogram to see if there's any perforations. And we'll also do a final angio if everything looks good without the guide wire to rule out perforations.
For sure.
So normally,
distal.
If everything looks good, we do 2 orthogonal views. If we don't use imaging, but if we use OCT, because we already have an angio to minimize that, we can only do 1. And the reason we do 1 is to rule out perforation, because all the other complications can be ruled out on OCT if it was done properly. I mean, so already here we can see the expansion ratio is like.
Can we switch the imaging?
1,060, not at 1,000, 116%, which looks perfect. So we're aiming for above 85 expansion ratio. That's what's recommended for OCT. It really depends on the reference of the vessel that we put.
But everything seems to be on assessment. You know, when you look at it, the expansion.
Mike, can you put the yellow?
Is very nice.
The red that's in the guides. The arrow to the left.
You mentioned the MSA that we see.
No, the other arrow.
Yep.
But the stent looks well expanded and well opposed. There's no dissections, and the expansion ratio is satisfactory.
Yep.
So I believe we are done.
Done. I think we're very happy. There doesn't seem to be any.
There's no perforation. The stent is well expanded. It's well opposed.
I think we're very happy.
No distal edge dissection.
Can we show a pre? So this is the pre when we wired it. Now show the post. So what we initially thought was the aneurysm was probably a healthy segment, the only healthy segment in that mid portion, and we managed to upsize it to 3.5. As you all know, with the OCT, sometimes you can even upsize to a 0.25 size in terms of ballooning versus IVUS. when we were talking about EEL to EEL. So that's what we did with a 3.5 to pulse dilate at 275 synergy. So there's no overlap, no dissections with anything. So I think we're done for the day.